Every year, hundreds of thousands of people go under the knife with one thought in their heads: my doctor said I need this. And a stunning number of them, more than the medical system will ever admit, didn't need it at all. Some of them come out with complications, some come out with consequences that will haunt them for years. Scar tissue, adhesions, chronic pain, disrupted circulation. And here's the part that should make you stop cold. This isn't about rare surgical errors or rogue physicians. This is a systemic pattern. Operations are being recommended not because they are medically necessary, but because that is how it has always been done. Because it is faster, easier, and, let's be honest, because someone profits from it. I'm Sam Waterling, and I've spent 15 years watching this play out in real patients. I've seen people walk into a clinic with a small problem and walk out with a big one. I know what it looks like when a person's life is altered by a decision that should never have been made. And I think it is my duty to say this out loud. Today I'm talking about 5 operations I would not have done on myself. And that, in all likelihood, are unnecessary for you too. The system doesn't make money keeping you well, it makes money treating you. Your next appointment is not where you're going to hear this. Subscribe and like if you want the truth. Help Dr. Waterling reach 100,000 subscribers. Let's start with the first operation. It is called diagnostic laparoscopy. 2 long words, here's what they actually mean. Laparoscopy is a procedure where a surgeon makes small punctures in the abdomen, inserts a tiny camera through those punctures, and looks at what is happening inside the abdominal cavity. The word diagnostic means the goal is not to treat anything. It is purely to establish a diagnosis. In other words, the person is being surgically operated on in order to figure out what is wrong with them. Let me walk you through exactly what happens, because the details are what they will never explain to you. The surgeon takes a specialized clamp, grabs the skin near the navel, pulls it taut, and drives a metal tube through the abdominal wall. That tube is called a trocar. This is not a fine needle. This is a hollow metal shaft with a sharp inner rod. The rod punctures through the layers of the abdominal wall, then it's removed, and an optical device, the camera, is fed through the remaining tube into the abdominal cavity. But here's the problem. The abdominal cavity is not an empty room. Inside, you have tightly packed intestines, a stomach, a liver. For the camera to see anything, space has to be created. To do that, carbon dioxide gas is pumped into the abdomen. The person is literally inflated from the inside. The abdominal volume expands, the pressure inside the cavity spikes sharply, and the diaphragm, the muscle that separates the chest from the abdomen and controls your breathing, gets pushed upward. Breathing becomes shallow and labored. If the surgeon needs to examine the pelvic region, the organs of the urinary and reproductive system, the patient is also tilted. Legs raised, head lower than the torso. The body is placed in a position it has never occupied in the entire course of ordinary human life. Think about what that means. Over your entire lifetime, your abdomen has never been inflated under gas pressure from the inside. This is a completely non-physiological situation. The abdominal wall is stretched in a way it was never designed to be stretched. The ligaments holding your internal organs in place, your liver, kidneys, intestines, are subjected to forces they were never built to withstand. Your ribs are pulled upward. The pelvic floor, the muscular platform that supports the organs of the pelvis, is compressed from above. When the gas is released and the procedure ends, the abdomen returns to its original size. But the tissues remember. Stretched ligaments do not snap back to their original state instantly. For weeks and sometimes months afterward, patients experience sensations that are difficult to explain. Discomfort in the abdomen, a sense of heaviness, a feeling that something is simply off. This does not appear in the medical records as a complication, because formally there were no complications. The operation went clean, but the body remembers. And then there are the puncture sites themselves. In medicine, there is a principle that applies without exception. Any disruption of tissue integrity heals through scar formation, every time. The external scar, the one you can see on the skin, is only the tip. Underneath it lies scar tissue in the muscle, in the fascia, the dense fibrous sheet that wraps around muscles and organs, and potentially in the peritoneum, the thin membrane that lines the inside of the abdominal cavity. Scar tissue is coarse and inelastic. It pulls. It can create adhesions, fibrous bands that form between organs which, under normal circumstances, should glide freely against one another. Adhesions following laparoscopy are not a rare complication. They are an expected outcome. And here is the most frustrating part. After diagnostic laparoscopy, surgeons frequently find nothing. Or they find exactly what was already visible on ultrasound. Or they find changes that require no treatment. The person went through general anesthesia, had their abdomen punctured and inflated with gas, was tilted upside down, and the result is everything looks fine, no pathology detected. Then a month later, the patient has abdominal pain. And that pain is a direct consequence of the procedure. My position is firm. Diagnostic laparoscopy is acceptable only when all non-invasive methods, meaning methods that involve no punctures, no incisions, have been fully exhausted and have provided no answer, and when the clinical situation demands an urgent decision. Modern medicine has access to high-resolution ultrasound, MRI, magnetic resonance imaging, with multiple contrast protocols, CT scanning, computed tomography, and laboratory panels with a broad range of diagnostic markers. That is a powerful arsenal. Using it fully and skillfully, that is the physician's art. Puncturing the abdomen is not a diagnostic act. It is diagnostic surrender. The second operation I want to address in depth is the surgical repair of an umbilical hernia. Let's start from the beginning because understanding the mechanism is everything here. A hernia is the protrusion of an internal organ or part of one beyond the cavity it belongs in, pushed out through a weak point in the surrounding wall. In the case of an umbilical hernia, that weak point is in the front of the abdominal wall at the navel. Through that opening, a loop of intestine or a portion of the omentum, a fatty fold inside the abdomen that serves a protective function, can bulge outward. Why does that weak point exist in the first place? Behind it is a weakness of connective tissue. Connective tissue is the structural framework of the entire body. It forms ligaments, tendons, joint capsules, blood vessel walls, and the fascial wrappings around muscles. When connective tissue is inherently weak, these structures fail to hold load the way they should. In some people, that shows up as varicose veins. In others, it's hypermobile joints. In others, it's hernias. These are all the same underlying problem, connective tissue weakness, just presenting at different addresses in the body. In newborns, umbilical hernias are extremely common. By various estimates, they occur in approximately 1 in 5 infants. After the umbilical cord is cut, the umbilical ring, the opening through which the cord's blood vessels passed, is supposed to close. In the majority of children, it closes on its own over the first few years of life. By the age of 5 to 7 years, school age, the overwhelming majority of umbilical hernias in children have resolved entirely without any intervention. They simply disappear. Because the connective tissue matures, the muscles strengthen, and the umbilical ring closes itself. Surgeons know this, and yet operations are frequently offered, sometimes to children of 2 or 3 years old. The surgical logic has a certain internal consistency. A sutured ring definitely will not reopen. But the real question is different. Does it need to be sutured at all if it is going to close on its own? Every operation means anesthesia, it means stress on a child's developing system, it means a scar. Why accept all of that when nature will handle it without a scalpel? There are genuine situations where surgery is necessary. A very large hernia opening, technically called a large hernia orifice, through which a significant portion of intestine can pass, is one of them. The other is the risk of incarceration. Incarceration means a loop of intestine or omentum passes into the hernia and becomes trapped. The blood supply is cut off and tissue necrosis begins. Necrosis means the tissue dies. That is an acute emergency requiring immediate surgery. If a segment of intestine is already dead by the time the patient arrives, it must be removed and the remaining ends rejoined. That procedure is called intestinal resection with anastomosis, and it carries far greater risk than a routine elective hernia repair. Those are the cases where earlier intervention was genuinely warranted, but those cases are the minority. The majority of umbilical hernias, especially in children, do not incarcerate and they close spontaneously. My practical advice, if you or your child has been diagnosed with an umbilical hernia and surgery has been proposed, do not rush. Ask the surgeon specific questions. Ask what the actual risk of incarceration is. Ask what size the hernia orifice measures. Ask whether watchful waiting is a legitimate option. If the answers are vague, go to another surgeon, then a third. If all three say surgery is indicated, there are grounds for it. If opinions diverge, you have both time and choices. Now, what you can actively do on your own. There is one exercise I recommend to every patient I see with any abdominal wall hernia, umbilical, inguinal, femoral, or linea alba. This exercise strengthens the transverse abdominal muscle. Let me explain what that is. The transverse abdominis is the deepest layer of the abdominal musculature. It wraps around the torso like a natural corset, and its primary function is to hold the internal organs in place and maintain intra-abdominal pressure at a stable, healthy level. When this muscle is weak, pressure inside the abdomen does not distribute evenly. It concentrates at the weakest points. The umbilical ring is one of them. Here is the exercise. Stand upright or lie on your back. Slowly and as deeply as possible, draw your abdomen inward. Pull the navel literally toward the spine as far as you can. Hold that tension. Now, while maintaining that contraction, try to deepen it further. Pull even harder. And then again. Keep going until you feel a deep burning in the abdominal muscles, until you've reached your true limit. Then, a slow exhale and full release. Do this daily. Within a week, you will feel the abdomen pulling tighter. Within a month of consistent work, the effect will be visible. Women dealing with diastasis recti, which is the separation of the rectus abdominis muscles that frequently develops during pregnancy, report that with regular practice of this exercise, the separation begins to narrow, sometimes without any surgery at all. There is another mechanism worth understanding here. Behind many abdominal wall hernias is visceral ptosis, the downward displacement of internal organs. The intestines shift downward, press against the front of the abdominal wall from inside, and increase pressure directly on the weakest points, the hernia openings. If the goal is to stop a hernia from growing and avoid an operation, the cause must be addressed. Strengthen the muscular corset and correct the organ displacement. This is achievable. It works. I have seen it work in my patients many times. Now we move to the third operation, and this one will surprise many of you. Because I am talking about an intramuscular injection, a shot. Is a shot in the gluteal muscle an operation? Yes. From a strict medical standpoint, it is a minor surgical procedure. That is not a metaphor or an exaggeration. That is the classification. By definition, any operation is an intervention in which the integrity of the skin and underlying tissues is violated. An intramuscular injection meets that definition completely. And like every operation, it carries requirements for sterility, specific technical demands, and complications. Let me walk you through exactly what happens to the tissue with every injection. The needle enters the skin, passes through the subcutaneous fat layer, and penetrates into the muscle. Along that entire path, it is cutting and displacing tissue. That is mechanical damage. Then the medication is injected under pressure. It does not simply fill a waiting space. It forcibly separates muscle fibers, creates a cavity in the muscle tissue, 1 to 5 milliliters in volume depending on the dose. Then the needle is withdrawn. The body begins repairing the damage, and it repairs it the only way it knows how, by forming scar tissue. 1 injection, 1 scar. Small, functionally almost imperceptible. 10 injections, 10 scars. A course of 20 intramuscular injections, and the muscle begins to resemble something considerably denser and more rigid than living elastic tissue. I worked as a nurse in an oncology ward, and we had patients who came back for repeat rehabilitation courses, who received long vitamin injection series. Some of them had gluteal muscles that had become literally hard. To get the needle in, you had to apply noticeable force. That is not colorful language, that is a clinical fact I witnessed firsthand. Oil-based solutions are particularly aggressive in this regard. These include fat-soluble vitamins, vitamin D, vitamin E, vitamin A, and certain hormonal preparations. A water-based solution is absorbed into the bloodstream relatively quickly after injection. An oil-based solution dissolves slowly. sometimes very slowly. That means a foreign substance sits inside the muscle for an extended period, sustaining an inflammatory response. Inflammation becomes scar tissue, and the scarring from oil-based injections is coarser, denser, and more functionally significant. Now, the complications. The mildest is local tenderness and palpable hardening at the injection site. More serious is an infiltrate, a firm, persistent lump of medication and inflammatory fluid that does not resorb on its own. More serious still is an abscess. That is a pus-filled cavity inside the muscle. I worked in a department of purulent surgery, and I saw those patients. Their gluteal region was opened surgically, drainage tubes were placed to allow the pus to flow out, and they were unable to sit or walk normally for weeks. It all began with a harmless injection. Infection can occur even with full sterile technique, in patients with compromised immunity, with diabetes, or when circulation in the area is already impaired by prior scarring. There is one more risk that is rarely discussed. The sciatic nerve passes through the gluteal region, the largest nerve in the human body. It governs both movement and sensation throughout the entire leg. If the needle contacts it, the result is sharp pain, numbness, and impaired leg movement. In severe cases, permanent neurological deficits. This is precisely why injections are given in the upper outer quadrant of the gluteal muscle where the nerve does not pass. But proper technique demands real skill, and not everyone has it equally. I have heard from patients, one nurse gave me a shot and I felt nothing. Another gave me one and I was dragging my leg for 3 days. That is not random variation. That is the difference in technique. The practical takeaway is simple. If a medication exists in tablet or capsule form, take it by mouth. The bioavailability, meaning the percentage of the substance that actually reaches the bloodstream, in modern oral formulations is comparable to injectable forms. Vitamins in capsules work no worse than injections. Antibiotics in tablet form are equally effective as injections for the vast majority of infections. There is no reason to fill your muscles with scar tissue for an effect you can get without it. Injections belong only where there is truly no alternative. Emergency situations, compromised gastrointestinal function, or medications that have no oral form. The fourth operation is surgical facelift, known in medical terminology as rhytidectomy. In plain terms, through incisions along the hairline and behind the ears, a surgeon tightens the skin and muscles of the face, removes excess, and fixes everything in a new position. The goal is to smooth wrinkles and restore the jawline. On the surface, an appealing idea. In practice, an intervention with risks that are fundamentally different from operations performed on other parts of the body. Start with the scars. Every incision produces a scar. In the facial region, that means disrupted blood circulation along the entire perimeter of the incision. Scar tissue does not conduct blood as efficiently as healthy tissue. The skin fed by vessels that pass through a scarred zone receives progressively less oxygen and fewer nutrients. The result? That skin ages faster. Here is the paradox. An operation designed to fight aging accelerates aging. Not immediately, but it does. The second issue involves the muscles of the face specifically. These are a uniquely different group of muscles. Unlike every other muscle in the body, facial muscles do not attach to bone. They attach directly to the skin. That is precisely why we can express emotions. We can smile, frown, and raise our eyebrows. The facial muscles are connected through a network of fascia, dense connective tissue sheaths, to the rest of the body. The jaw muscles, the neck muscles, the trapezius that extends down to the shoulder blades. This is not theory. This is anatomy you can verify on yourself right now. Close your eyes and tune into your body. Scrunch your entire face with maximum effort. Eyes, nose, mouth, forehead, as tight as you can. Notice what happens in your neck, shoulders, and chest. There is a subtle but real tension response through the whole system. Now release your face completely. Add a gentle half smile. Feel how the body drops, softens, settles. This is not a psychological effect. This is physiology. The muscular chains connecting the face to the rest of the body are real and they are active. When a surgeon pulls and fixes the muscles of the face in a new position, he is altering the tension throughout that entire chain. The muscles begin operating differently. This changes head positioning, neck muscle tone, and posture. That influence is difficult to measure precisely, but it is real. And it always moves the system in the direction of disruption, not improvement. The third risk is specific to the face: asymmetry. No human face is perfectly symmetric. That is completely normal. But it also means the muscles on each side of the face are in different states of contraction and length. And that asymmetry shifts across different zones of the face, with the right side dominant in some areas and the left in others. A surgeon who performs the procedure with technical perfection, doing everything geometrically symmetric, may fail to account for this baseline tissue asymmetry. And the result looks unnatural: a tilt, one eyebrow sitting higher than the other, a corner of the mouth pulling to one side. These outcomes are not isolated cases. They are frequent enough to constitute a systemic risk. And the most important point, the one almost never raised in the context of cosmetic procedures: your face ages harmoniously. Nature performs this process gradually, evenly, proportionally. Wrinkles appear where the skin worked hardest: around the eyes, around the mouth. These are the marks of a life lived, the record of emotions expressed. They look natural because they are natural. There are people whose maturity is genuinely beautiful precisely because they did not intervene. When we intervene, even with the best intentions, we break that harmony. One area of the face looks 20 years younger, the rest does not. And that mismatch is visible, always visible, because the eye perceives any disruption of a natural process as something wrong. What works instead of surgery? First, and most powerfully, circulation. The finest cosmetic in the world is your own arterial blood. It delivers oxygen, nutrients, and growth factors to every tissue. When blood flows freely to the face and drains freely through the lymphatic vessels and veins, the skin looks alive, firm, and vital. What blocks that flow? Muscular tension in the neck, poor posture, physical inactivity, chronic stress that keeps the muscles locked in a constant low-grade contraction. Second, facial exercises. They work. Here's a simple one. Place both palms gently over your face, your forehead, cheeks, and chin. Without sharp movements, apply a very gentle upward pressure. Not a pull, but a direction. Hold this position for several minutes. Then slowly remove your hands, maintaining that upward orientation in your mind. You may notice that on one side the tissues feel more yielding, and on the other there is slight resistance. That is the asymmetry. Work with equal pressure on both sides. With regular practice, the tissues genuinely begin to lift. This is not mysticism. It is stimulation of lymphatic drainage and improved tissue nutrition. The fifth operation is cesarean section without medical indication. Let me be direct from the start. When the indications are real, this is a brilliant operation. Placenta previa, when the placenta covers the cervical opening and blocks delivery. A persistent transverse or breech position of the baby that creates genuine risk for natural birth. Acute fetal hypoxia, when the baby is no longer receiving sufficient oxygen and minutes matter. In those situations, cesarean section is life-saving. Without it, catastrophe. I am not talking about those cases. I am talking about situations where a woman requests a cesarean because she does not want to go through labor, because she wants to choose the birth date, because she is afraid, or because a physician recommended it without specific indications, simply as a default, as a precaution. Here's what happens to the mother. A cesarean section is a major abdominal operation. The front of the abdominal wall is cut open and the uterus is opened. General anesthesia or spinal anesthesia, an injection into the spinal canal that numbs the lower half of the body, is required. The baby is extracted. The uterus and abdominal wall are closed in layers. A scar remains on the uterus permanently. In any subsequent pregnancy, that scar carries specific risks. Possible placenta accreta, in which the placenta grows directly into the scar, and possible uterine rupture along the scar during labor, which is a life-threatening emergency. The abdominal scar is painful, sometimes for several weeks. Rolling over in bed, standing up, lifting the baby, all of it causes pain. I have heard patients say, "I thought it would be easier than natural labor. Then the anesthesia wore off and I realized I was wrong." That is not an isolated story. That is a pattern I hear regularly. The post-operative recovery after a cesarean is substantially harder than recovery after a straightforward vaginal birth. After a natural delivery, a woman is on her feet within hours. After a cesarean, within a full day and only with difficulty. Breastfeeding is harder to establish because the hormonal cascade that initiates milk production is normally triggered by the physiological process of labor itself. Now, the baby. And here is information that most people simply do not have. During passage through the birth canal, a process called bacterial colonization occurs. The newborn receives the mother's own microflora, the bacteria that naturally inhabit the birth canal. These bacteria become the foundation of the infant's intestinal microbiome, its first line of immune defense. This is not theoretical. It is an area of active, rigorous scientific research. Babies born by cesarean section do not receive this primary colonization. Instead of the mother's bacteria, they receive whatever is present in the operating room environment. The measurable consequences: statistically higher rates of allergic disease, atopic dermatitis, a chronic immune-mediated skin inflammation, bronchial asthma, and gastrointestinal difficulties in early childhood. In addition, the physical compression of passing through the birth canal stimulates the baby's lungs in a way that helps expel the fluid that has filled them throughout pregnancy. That is the physiological preparation for the first breath. During a cesarean section, this does not happen. Infants born by cesarean require additional respiratory support more frequently. The first independent breath is harder for them to take. Childbirth is the one area of medicine where learning from mistakes is categorically unacceptable. The cost of an error is the life and health of two people simultaneously. If you are planning a birth, or if there is a pregnant woman in your life, approach this with full seriousness. Find an obstetrician-gynecologist with real experience managing vaginal delivery. If a cesarean is being proposed to you, ask directly, what are the specific indications? What exactly, in my case, makes a cesarean necessary? If the answer is unclear, find another specialist. Here's something worth knowing from a purely clinical standpoint. Every risk discussed today, the risk of scar formation, adhesion development, and complications following any surgical procedure, is measurably higher in people over 40 years old. After 40, connective tissue heals more slowly, scars form more densely, and the tendency to develop adhesions increases. Which means the price of an unnecessary operation rises steadily as you get older. How old are you? Write it in the comments. I want to understand the age profile of this audience so I can focus future content on the risk factors that are most relevant to where you actually are right now. So, what do you do after watching this? First, you do not make a decision about surgery in a single doctor's office on a single visit. Any elective operation is a decision that requires time and a second opinion. Ask your surgeon a direct question. What happens if I decline the operation? What changes in 3 months, in 6 months, in a year? If the answer is evasive, take a pause. Find a second specialist. Find a third. Compare their positions. In parallel, look for conservative options: exercise, nutritional correction, physical therapy, and lifestyle modification. Many conditions that are routinely classified as surgical stop being surgical under a well-executed conservative approach. This is not wishful thinking. This is evidence-based medicine. This is what I see in my practice. And remember one thing, medicine has a principle that is short and powerful: primum non nocere. First, do no harm. This is not a slogan, it is the foundation. The best operation is the one that turned out to be unnecessary. The healthcare system is not built to keep you healthy. It is built around procedures, referrals, and operating rooms. Nobody in a clinical setting is going to lay this out for you the way I just did. Subscribe, hit like, and help Dr. Waterling reach 100,000 subscribers, because this is what 100,000 people need to hear.